എന്നേക്കും തന്നെ ആമേൻ. പരിശുദ്ധനായ ദൈവമേ, സ്വർഗസ്ഥ പിതാവേ, ഈ മാസത്തിൻ്റെ രണ്ടാമത്തെ വ്യാഴാഴ്ചയ്ക്കായി നന്ദി സ്തോത്രം അർപ്പിക്കുന്നു. വീണ്ടും ഞങ്ങൾ പുതിയ കാര്യങ്ങൾ കേൾക്കുവാൻ അതനുസരിച്ച് ഉള്ള വളർച്ചയിൽ ഞങ്ങളുടെ ഹോസ്പിറ്റലും സ്റ്റാഫും മറ്റുള്ള കാര്യങ്ങളും മുൻപോട്ട് പോയിക്കൊണ്ടിരിക്കുന്ന സമയത്ത് ഇന്നും ഞങ്ങളോട് ഇടപെടണമേ എന്ന് ഞങ്ങൾ പ്രാർത്ഥിക്കുന്നു. ഇന്ന് ഞങ്ങളോട് സംസാരിക്കുവാൻ പോകുന്നതായിട്ട് ഡോക്ടർ ചിത്ര തോമസിന് വേണ്ടി പ്രാർത്ഥിക്കുന്നു. ദൈവത്തിൻ്റെ സാന്നിധ്യം കൂടിയിരിക്കണമേ. അത് ഞങ്ങൾക്കും നമ്മുടെ ഹോസ്പിറ്റലിനും മുൻപോട്ടുള്ള ഞങ്ങളുടെ പ്രയാണത്തിലും അത് അനുഗ്രഹമാക്കി തീർക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. വന്നു ചേർന്ന ഓരോരുത്തരെയും അനുഗ്രഹിച്ചാട്ടെ. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, everyone. Respected faculty members, dear teachers, students, and all healthcare workers. It's a privilege to welcome you all to this important session of Quest. We have started the Mind Matters project around a month back with the purpose of improving the mental health and well-being of all the healthcare workers at our institution. So why we started this is based on data. The study done by IMA Kerala shows that doctors or the healthcare workers die around a decade earlier than the normal Kerala population. Why this happens is the cause of death is other cardiovascular disease, cancer, and suicide. So we are losing 10 years. So it's not because we have bad genetics, it's not because we are at more risk, it's all related to mental health. I can vouch that it's all related to mental health. And when I say mental health, people think it's all in the mind, but no. In our body also there are changes which are happening day by day. So today we have a wonderful speaker who will take us into the depths of what we are looking at. I take this moment to invite Dr. Chitra, who is actually heading our Mind Matters project, to lead us with the next session.
We are all here because we care deeply about patients, patient first movement. But there's this quiet crisis that we overlook, the well-being of the very people who deliver that care. Many of us know how to manage a crashing patient, but do we know how to manage a crashing colleague or even ourselves when we feel too overwhelmed? Good morning all, I'm Dr. Chitra Thomas. I'm a senior resident in the Department of Psychiatry. Thank you for this opportunity to speak. This session is not about questioning how we have worked so far, but it's about how we can support each other better, especially during this time when fatigue, burnout are silently affecting our ability to do our best for our patients. So the topic today is scrubs and stress, the mental toll of medicine. This is done by, of course, Department of Psychiatry and Psychology and also the Mind Matters project. Dr. Riya is here. She is spearheading that project. Okay, so I'm just going to take you to a poll. If you can scan the QR code, you'll need your internet. Your answers will all be confidential and you will see what the polls will come up as. You can vote. Well, how would you rate the importance of mental health in healthcare workplace? So, extremely important, moderately important, not a priority, not sure. So I think most people think that it is extremely important. That's good to know. The next question is, what is your current level of work-related stress? Someone said it's very high. To at moderate, mild. Okay. Okay, so I think the moderate has it. Do you feel supported by your team during stressful times? So sometimes. Okay. If a colleague has hinted at suicidal thoughts, would you know how to respond? Okay, so somewhat I have a general idea seems to be the winner. Okay, now going back to the presentation. So, the reason why we are doing this, like Suman sir said, we have estimated, from the studies all over the world, we have found that 300 to 400 physicians are dying by suicide alone every year. And male doctors are far more likely, 40 times more likely to commit suicide than other men in general. And up to 60% of doctors and nurses report burnout symptoms. And this came to light more so during COVID-19, right? During the pandemic, and after that, there were a lot of studies which were done which showed that fatigue and stress are very problematic in the healthcare community. So the Thiruvananthapuram native doctor was my junior. And there are many other stories like that. In fact, I lost a colleague. Before coming to Believers, I was working in another establishment. And I lost a 28-year-old colleague to suicide. Again, no one knows. The problem with suicide is there are more questions than answers when that's the cause of death. 28-year-old speech therapist who was a brilliant speech therapist, loved by his peers, loved by his patients, one day found hanging at his home by his mom. Left a lot of questions. So this is one of the reasons why I am committed to this project. Now, why does this happen in healthcare professionals? Individual factors are there, work-related and social factors. So individual factors, most of us who have entered into medicine or any medical field have perfectionistic traits. We aim to reach the maximum level of achievements. That is, in terms of our degrees, in terms of our work ethic, we place ourselves on a high pedestal. Another thing is, of course, our age, family responsibilities, whether we are married, divorced, if we have children. People who have younger children tend to be more stressed because, of course, they have 2 jobs working parallel. Women tend to be stressed. I'm not saying this from my perspective, but that's what the studies have shown. And of course, the fact is our own personality, how resilient we are as human beings. All of these are individual factors. Many people have taken out loans for their education. That also plays a role. Debt, right? All of this. That is individual factors. Now, work-related factors. The time pressure. People who have worked in government will know that you cannot control the pace of patients. If you have to see 200 or 300 patients, you have to see it. You cannot put a number and say, I'm going to see 20 patients a day. So that puts you at risk of burnout. There's a chaotic environment. There is unfavorable organizational culture. And many a time, even in med school, we are taught that there's a hierarchy, there is ragging, and then later on there is bullying. But we accept it as it is. It's helped all of us in some way, but there may be some individuals who are weaker than the rest of us. They may not be able to cope with that stress. Then, of course, coming to administrative tasks. Not all of us are meant for administration. So when given it to us, we can't obviously say no. So we'll do that, but unwillingly. And many doctors and nurses feel they're not sufficiently compensated or reimbursed. So that's also another issue. Then, of course, the social factors. The social factors include the negative portrayal of healthcare workers, especially during recent times where everything is in the news. And there's a lot of social media trials that happen and a lot of lives lost because of that. So, why are we bothered? One is, of course, the patient care, the individual, the doctor or the nurse, and of course, the bigger picture, the healthcare cost. Coming to the patient care, you don't want to build relationship with your patients if you're burnt out. If you're tired, you don't want to listen to their stories or their pain. That's called compassion fatigue. There is increased risk of medical errors, increased risk of malpractice suits, patient satisfaction goes low, and this affects the quality of care and patient outcomes. Coming to the staff themselves, there is an increased risk of motor vehicle accidents and near-miss events, stress, disruptive behavior. By disruptive behavior, I mean anger outbursts, throwing things in the OT, all of that, mood disorders, depressive episodes, and increased use of alcohol, cannabis, MDMA, all of this, especially among healthcare workers. I hate to say it, but surgeons lead the substance use, and there is suicidality and twofold increased risk of suicidal ideation. Now, coming to the bigger picture of healthcare, when a staff member repeatedly takes leaves that because of their stress or for whatever reason, the physical problems associated with stress, then they'll eventually depart from the hospital because they're not happy with the environment. And inevitably, the HR has to spend more money on recruiting more people, training more people. So all of this translates to a loss-loss situation in all areas. So what does stress look like in scrubs? 4 areas: emotional signs, behavioral clues, physical signs, and the professional impact. Emotional signs include mood swings, irritability, feeling overwhelmed, panic attacks, and compassion fatigue, as mentioned earlier. Behavioral clues include you withdraw from society entirely. You don't want to talk with your colleagues or have tea with them. You don't want to talk to your patients. There is increased risk of errors and forgetfulness and substance use. The physical symptoms include fatigue in spite of getting adequate rest, headaches and body aches, insomnia or excessive sleep, and because of the gut-brain axis, gastrointestinal issues. We don't eat food on time. We'll wait for the next patient to come, finish all the patients before we go into lunchtime. So that can lead to physical symptoms. And the professional impact. You are not satisfied with your job. You feel tired coming into your job. You feel trapped in your work. You start questioning your career choice. Earlier on, I think the previous generation, they used to stay in their job irrespective of what happens. But nowadays, there is a lot of opportunity. Many doctors are becoming content creators because that seems to pay higher. And that seems to be more rewarding in some sense. And all of this leads to a lack of personnel as well as decreased performance. So stress in scrubs is real, and recognizing it is the first step we can take towards healing. So now I go on to a scenario. Again, I would like to get your opinion. The exhausted resident. Dr. A, a first-year resident, has been working 80 plus hours a week, faces constant criticism and public humiliation from her consultant. She's anxious before rounds, has stomach aches before work, making minor errors in documentation, appears irritable during rounds, and has confided in a colleague that she feels like a failure and dreads coming in. What would help her most right now? I'm going to just... There's no right and wrong answer. This is just a poll to get your awareness or... Okay, so more people have said that someone to talk to would be a good thing for the resident. Okay, so while that's a good thing that we get someone to talk to, but not always, right? We don't always have someone to talk to. And the important and key point here was that this person was working 80 plus hours a week. So there is that physical component of exhaustion that has stepped in. So what would be ideal would be getting a break or a rest, if that were to help. Okay. Sorry. So what is burnout? It's a psychological syndrome which is characterized by emotional exhaustion, depersonalization, which means that you feel like you're looking in from outside, you're working like a robot, you're very mechanical, or working at a spinal level rather. A sense of reduced accomplishment in day-to-day work, or what the new generation calls as imposter syndrome. That in spite of all your achievements, you still feel like a failure. Okay, that does not come from a place of humility, that comes from a place of lack of pride in your own work. So this is a stress response curve. Now, many people may feel that even the smallest challenge presents a big problem, but no, we need small challenges and small stresses on a day-to-day life to prevent boredom. So at the optimum level, we have a comfort zone. That is where you have your adequate rest, you're able to take breaks, you're able to take your vacations, you're able to come into work and give your 100% at work. That's your optimum. And you have adequate interaction with your staff as well as the patients. Then you're stretched. When you're stretched, maybe one or the other thing goes. That is, maybe it's your physical, biological needs. Your sleep may get deprived, or maybe you have lost a patient. So that's your stretch stage. But still you will function at some optimum. Then comes the strain part. The strain is when you are fatigued, you have been working 3 days continuously, you have lost a patient or two in the last 3 days. That's when you start making bad decisions. You will be tired, you want to go home. Okay? That's still in the strain stage. The crisis is when you're exhausted and you have other health problems also along with this. For example, maybe you're a diabetic, you're hypertensive, right? You start having severe migraine. And that's when you experience burnout. And that's a crisis stage for you, right? And that's where your performance goes down. And you're not good for your patients, you're not good for yourself as well. So how we can prevent is red flags. Like in every other disorder, we have red flags, right? So red is for rage. You get angry very quickly at your juniors, seniors. You're not really thinking. Emptiness, you don't feel a sense of accomplishment. You're depressed, or you're despondent, or you have low mood. Fatigue, you have low social battery. You don't want to talk to anybody. Anhedonia, you don't have the pleasure you don't have any interest in things you used to enjoy before. Guilt of letting people down, so you stay on. Self-doubt or low self-esteem. So, since I'm a psychiatrist, I have to tell something about individual relaxation techniques. So, one is box breathing. This is what we do even in our OPD when a person is having a panic attack. So, you can see the box here. And ideally what we would do is run our fingers so that from one end to the other end, you inhale, hold, then exhale on the other end, again inhale and exhale. Now, you may not have a box in front of you always. So what we can do is a 4x4 technique. That is 4 seconds, 1, 2, 3, 4, inhale. Maybe we can do it now if all of you are interested. Okay, so everyone please close your eyes. Okay, take a deep breath in. 1, 2, 3, 4. Hold. Exhale. 1, 2, 3, 4. With your mouth. Inhale with your nose and exhale with your mouth. Inhale. 1, 2, 3, 4. Exhale. 1, 2, 3, 4. Okay. You can open your eyes. I don't want anyone to go to sleep. So, another thing we do is abdominal breathing. So when we have a panic attack, what happens is we start breathing with our chest muscles. We are not capable of breathing with those. They're very small muscles, right? Ideally, we should breathe with our diaphragm. So when we do abdominal breathing, we breathe in and our abdomen comes out. And exhale, your abdomen goes in. This is something, again, you can practice. So breathing is something very crucial to relaxing. Another thing you can do is the 5-4-3-2-1 grounding technique. What we tell our patients who have anxiety is carry a chocolate or carry something in your pocket with you so that you can do this. That is 5 things you can see around you, 4 things you can touch or 4 things you can hear, 3 things, again, you can hear or touch, 2 things to smell, and 1 thing to taste. If you're a diabetic, you can carry nuts or something, but if you're not that health conscious, you can carry a chocolate. And chocolates have that effect of releasing dopamine, so you'll feel happy also in a way. So that's something that you can do as an individual, at the individual level. So some strategies to avoid burnout, like you practice self-care. That is not by, as our psychologist would say during the induction classes, Ivan says, it's not about using how many serums and sunscreens on your face. It's about having time for yourself, taking breaks, ability to get adequate rest at night, and eating a healthy diet. Take breaks, do something that you love, hobbies. Manage your workload. Make sure you don't leave it for the next day. And of course, identify your source of stress. If it's the management, you can't do anything, or if it's your senior, you can't do anything, but otherwise, maybe we can try and control it. Okay. Then set boundaries. Learn to say no. That's something none of us can do, especially in Kerala culture. It seems very, it's very frowned upon to say no when you're uncomfortable. Okay. And again, so I'll leave again one more poll. Okay. Do you exercise? Even I don't, so it's okay. I think the only one in our department who follows that is Dr. Suman. So the majority is at 55% of no, nobody exercises. And exercise doesn't include rounds. My husband says I go for rounds, so that doesn't count as exercise. So I think maybe we all should start thinking about our health, right? Start exercising. Maybe everyone knows, right? 20 to 30 minutes a day is good for us. Okay. Again, back to our presentation. So the second scenario is a silent nurse. Nurse B, an ICU nurse, recently lost a patient she was emotionally attached to. Since then, she has become withdrawn, avoids group lunches, and has been calling in sick more frequently. Colleagues are worried but unsure on how to approach her. She tells a colleague, I just don't feel anything anymore. What support would help her at this moment? Again, a poll. Someone to acknowledge my effort, protected time to pause and process, peer or senior checking in emotionally, team debrief to talk it through, option to step away for a short while. There are a lot of UK returnees, so I see that is being reflected in the answers. So the maximum people have said team debrief to talk it through, which is actually something that we don't practice in India, which is a must actually. What is a team debrief? The thing is, when we lose a patient, all of us may not be attached, especially in pediatrics. We feel very sad when it's a child. When it's someone, I'm not saying that old people are not important, but we still know they have lived their life to a certain extent and they have gone. But even then, it still hurts somewhere. So pediatrics, obs and gynae, that's where all of this pain comes in, right? So I had a professor in med school who had to do a decapitation on a child. She was a gynecologist. During delivery, the baby got stuck and had to decapitate. So she had to leave that place for a good 1 month to recover from that pain. The problem is we have mortality meets in our hospitals. But that's the place where we blame the doctors or the nurses. You are at fault, I didn't lose this patient, you did. But that's not helping anybody, right? Are you there immediately for that person who has lost this patient? That's what a team debrief is. It's a non-judgmental space. Obviously, you need to investigate to see what happens or what happened that led to this event, but also you support the healthcare worker who had been toiling. Obviously, there is some, we all give our 100% to our patients, no matter what. So when someone dies, it's sometimes there's some divine intervention also that plays a role, not just us, right? So again, another question. I'm sure all of you have lost a patient at some point or the other. What did you do right after you lost a patient? In India, the culture is you move on to the next task without a pause. I don't see that leading, but you found a colleague. That's a good thing, actually. You found a colleague or mentor to talk to. This is what did you do. This is not about what you could have done, but yeah. Found a colleague or mentor to talk to. Still very good. But what most happens, what commonly happens is that you move on to the next task. You move on to the next patient. Right. So how can we support someone who has lost a patient? Offer your presence and space. You normalize their feelings. They're feeling sad, they're feeling agitated, anger. Sometimes it can also be relief. I know that's a very scary thing to say, but it's the truth. Sometimes that person was having cancer, a terminal illness, they were suffering in front of our eyes, and you feel a certain sense of relief. You encourage peer or mentor support. You recognize their effort, and you follow them, look after them. You sort of talk to them over time, see how they are doing, are they coping well. Now, what needs to be avoided, of course, is the gruesome blaming game, ignoring or minimizing the event. I've heard in med school, like senior professors saying, "Enikku oru patient poi, ninakku 10 patient poi, ainenda." What is it? We lose patients. That is minimizing. We are talking about human lives. We cannot minimize that. Rushing to problem solve. Overloading them with new tasks, focusing only on the clinical outcome and assuming that they are fine now. Third scenario, I promise you there is only one more scenario after this. Nurse I returned from maternity leave recently and is struggling to balance night shifts with newborn care. She's constantly tired, forgetful, and recently left a medication tray unattended. She hasn't told anyone she's overwhelmed. What would have helped most during transition back? So it's not just about maternity, but also about anyone who had to take a leave of absence for health-related reasons. Just going to switch. The answers were gradual return of flexible hours, mentorship from another working parent, a quiet space for breastfeeding or pumping, emotional support or check-ins, non-judgmental communication from colleagues, and clear guidelines for reorientation. So gradual return of flexible hours has it. Okay. So how can return to work be more supportive for healthcare workers? So a friend of mine who's a gynecologist had recently given birth, and we were talking and she had said, I don't consider maternity leave as a maternity leave. It's a pause from one place and I'm starting work in another place. That's what maternity leave feels like. So oftentimes what happens is we make these statements, nee tirichetthiyo, suga aayirunno. That's very hurtful to a mother, രക്ഷപ്പെട്ടു കുഞ്ഞിനെ ആർക്കെങ്കിലും കൊടുത്തിട്ട് നീ വന്നേക്കാണല്ലോ ജോലിക്ക് ഹാപ്പി ആയില്ലേ. All of these are very judgmental comments that you can pass towards a new mother. It's a very painful process for a mom to leave her child and come to work. So what you can do is non-judgmental communication. Ask how she's doing, whether she's getting enough rest, And also, even if it's someone who had, let's say, a road traffic accident, has returned to work, how are you doing? Are you able to manage on your own? Do you need support? Do you need help? These are some non-judgmental communication statements. Emotional support, a buddy system, a supervisor can check in. Structural support, like obviously the flexible hours and protected spaces. A recommendation would be, maybe don't give them nights initially and, slowly integrate them into the system. Cultural support, of course, informational support. Of course, within the 6 months that we were away or 1 year that we were away, a lot of things would have changed. So, when the hospital I used to work earlier in, when I did my PG, there was this, I don't know, it felt very much like a punishment that when the nurse goes on maternity leave and she comes back, she's posted in a different department entirely. So she's coming, she's absolutely lost. And oftentimes it used to be in the psychiatry ward. I don't know why. It was a special brand of punishment for anyone who gave birth. So again, refamiliarize them with the system and orient them to the new updates. Mental health support, of course, peer groups, mother to mother or anyone. It can be anything that gives them support. Access to counseling. Okay, this is the last one. Absolute last, I promise. So Dr. J, a second-year resident, notices that her close friend and co-resident is showing signs of burnout and possible suicidal ideation. She is worried but fears breaching confidentiality. What immediate steps are needed when there is a risk of self-harm? Okay. Encourage them to talk and stay with them. Refer to a mental health professional directly. Report to supervisor quietly. All of the above, depending on urgency. In this, there's only one right answer, unlike the other questions. So all of the above is actually the right answer because we don't know what level they're at. And telling them, okay, go to a psychiatrist now would be traumatizing them for life. So just sit and talk to them. Now I'll show you what we can do. So like you have ACLS, BLS and all of that for all the other specialties, we have what we call as crisis intervention. Okay, so these are some things that you can do if someone has expressed suicidal ideation. Many a times, even today in our community, we fear asking about suicidal ideation. It's still taboo. People think that if you ask about suicide, that person is likely to go and commit suicide. That's not the fact. Actually, shows that you are interested in them. You are caring for a life. So you ask. Don't directly ask them, okay, are you suicidal now? No. You sit and talk to them, ask about their problems, and then say, okay, I see you're going through a difficult time. Are you thinking of ending your life, or do you have any such thoughts? Okay. Then you try to keep them safe. This is a place where people will tell you, okay, please don't tell anyone that I'm thinking like this. But this is not where you are sworn to secrecy. You have to tell somebody. If, like, suppose it's a student, you have to talk to their parents. If it's a colleague, again, spouse should be informed or their parents should be informed. Okay, if parents are the problem for the suicidal ideation, please don't go and inform them. But obviously find someone you can trust with the patient's health, right? Keep them safe. Many a time healthcare workers use narcotic substances for, suicide. Painkillers or something like that. Usually that's their method of suicide or sometimes even hanging. So try and keep them safe. Be there with them. Help them connect to some healthcare services, of course. And, many times what happens is, okay, I have referred them to the psychiatrist or psychologist. My work is done. In fact, many people will avoid talking to that person from then on. They'll be like, എങ്ങാനും ഇനി സംസാരിച്ചിട്ട് വീണ്ടും suicideാന്ന് പറഞ്ഞാൽ എൻ്റെ തല വന്നിരിക്കും. So they'll avoid talking to that person entirely. Please don't do that. Talk to them. Follow them up regularly. Like you would see any other patient or like you would see any other family member. Ask them how they are doing. Don't ask about suicide every day, but ask them how they are doing. Is their therapy going fine? Are you taking medications? Are you okay? That's what you do in crisis intervention. So do's and don'ts, just again, do talk openly and matter-of-factly about suicide. Listen. Allow the expression of their feelings and accept their feelings. This is a US crisis line. We also have in India. The NIMHANS hotline is there. So offer hope that alternatives and also telemanus, that is by DMHP, District Mental Health Program, Offer hope that alternatives are available, but do not offer glib reassurance. Supposing a person has a debt of 50 lakhs, please don't tell them, hey, I will help you solve it. That's not going to happen. So we'll try and figure it out. Take action. Remove means like weapons or pills. There are some people who bring religion and feelings into this. That is, it's against your moral values. Don't you value life? That brings a sense of guilt into that person who's already on the brink of suicide. So I'm going against my religion. I'm going against my, family. I'm bringing dishonor to them. Again, the thought will be, I'm a failure. I should die. So don't do that. Lecture them on the value of life. No, they know that their life is valuable. Somewhere they feel there's no way out. That's why they're trying to end their life. Don't dare them to do it. Don't act shocked. This will put a distance between you and them. And again, like I said, don't be sworn to secrecy. Okay? You have to seek support. So some interventions that we can do to create a burnout-resistant workplace, the individual, organizational changes, as well as supportive policies. At the individual level, so sometimes it's not just the system, it's also the individual. We have a skill deficit, we don't know something, and that's what's causing stress. Then we learn that skill, right? Make ourselves better. So this is where we use this term called resilience. What is resilience? I would say it is like you talk about a rubber band. You stretch, but it comes back to its original shape. So it is the ability to bounce back from a difficult situation, learn to adapt to the challenges, and recover from any adversity that may arise. But again, like a rubber band, women will know it. When you use a rubber band for too long, it loses its elasticity. So don't try to test a person's resilience. Okay, you have a strong support network around you. People you trust, who you can confide in. You stay updated with the industry advancements. You learn from your setbacks, and you use problem-solving skills and adaptability, and find purpose in your work and maintain a positive outlook. And if nothing helps, seek professional help. I feel I need to talk about this because there are some students who have told us that when they felt overwhelmed and they told their professors, this happened in Believers, I'm very sorry to say, but their teachers discouraged them from consulting the psychiatry and psychology department. So I think that needs to change. And there's no shame in accepting the help from a mental health professional. So seek professional help. So these are my suggestions for the management level. So staffing, of course, unless you have adequate number of people working, the people who are already working cannot take breaks, right? Normalize protected breaks and rest, and promote a culture of psychological safety. It's safe otherwise. We have all of those needle prick safety, all of that is there. But we don't have something called psychological safety. Okay. Definitely Believers has invested in mental health support, right? Recognize and respect a person's autonomy, a doctor's autonomy. There are some hospitals in Pathanamthitta itself, not Believers, but where the management takes full effort into interfering in the patient care guidelines, what's being done to the patient. And these are non-medical professionals who are looking into this. That definitely disrespects the autonomy of the doctor and the nurse. Strengthen return to work transitions and, of course, leadership training. This is something, again, we have some action plans for this. And, of course, feedback loops and listening mechanisms. So what we have done so far is, since April, we are giving mental health awareness during the induction programs that's by the HR department. And since May 2025, we have the Mind Matters Clinic, which is done in liaison with the Family Medicine Department on all Tuesdays from 8 a.m. to 1 p.m. Okay. So what is the action plan? Dr. Suman will talk about the action plan, what we have for the future. One would be we have some research coming up by Dr. Ria, or Dr. Ria can speak actually. Please come. Ma'am, please come. This is your project. She needs to come. She'll never come in the forefront. We're also thinking maybe this is again a suggestion for the management. We can set up a helpline because the whole point of keeping a Mind Matters clinic was we wanted to avoid the stigma of coming to the psychiatry OPD. So if we can set up a helpline where you can talk to the mental health care professionals over phone, so we can avoid even seeing us. right? So that's something maybe we can discuss in the future, right? Okay. So I'll just finish off and give the podium to Dr. Ria. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic and as expecting to be able to walk through water without getting wet. This is by Dr. Rachel Naomi Remen. So thank you for giving me your patient ear. All of you are pressed for time, so I'm not going to keep you here any further. I'm giving the mic to Dr. Ria. Thank you.
Yeah, thank you, Dr. Chitra. So, Dr. Chitra said I'm heading Mind Matters. I'm more like the cheerleader for Mind Matters. There are a lot of smart people here. So, I thought how we can get together, everyone, to address this very unaddressed problems. For me, I think what motivated me to this project is when I was doing my film school, we had the script writing exercises, and I realized that things which patients whom I had seen terrible deaths, and even as medical students or interns were the first things which used to hit my head when I was asked to write the stories. So that was a kind of wake up call for me, because we work in a health atmosphere where people in their most vulnerable states come and there is no rational emotions. And day in and out, we are actually trying to help these kind of people. So, but we never address it. So we are one of the most, I mean, as healthcare professionals, we are one of the most group which actually have to deal with vulnerable populations day in and out. Vulnerable in the sense that there is no rational emotions, they come at their lowest points. A small thing can trigger angry reactions, or even like small good things can trigger like gratitude, immense gratitude. So this is the atmosphere we work. And I realized that when we actually, being a public health professional, when we compare countries, there's only one difference which I see between like countries who actually address good mental health and here where it is unaddressed. There's something called loci of control. In places where there is a high loci of control, people feel that we can do something about what we see. In places where there is low loci of control, we are like, okay, everything is going as it is and we can do nothing about it. And India actually, if you see many of the studies at global health levels, due to our history of being suppressed, and we'll see that this is actually translated into many of our actions today. We feel that we don't have much control about what is happening in our environment. But I think it is way past time we overcome that, and I'm really sincerely hoping that our institution can be a model to set up an example on how health institutions can address mental health problems. So the future plans, I mean, it's a collaborative effort between management, HR, psychiatry, family medicine, social service, and anyone who is interested. And also we have invited students. So there's a student innovation club. They themselves had come up with problem statements, and they are trying to see what innovative solutions we can do to address it. And we are also trying to see through a research lens. There's a new word which I learned, work-life harmony. So using that tool, trying to see, maybe it's we are always focused on work-life balance. Maybe there are a lot of environmental, like if we compare to the West, I don't think we are in a position to compare to the West with 1.4 billion people sitting, and we have very less health professionals to take care. So we might have to look into some other tool called work-life harmony. How can we be happy actually doing what we do? So that is something which we thought we look at with a gender lens as well as like various designation lens. And also, there is a clinic which is open, run by Dr. Chitra, which is Mind Matters Clinic, which, as she said, Tuesdays it's open, 8 to 1. Please, in case if anyone wants to come anonymously also, you can contact HR or anyone, or you can contact her directly. Yeah, you can contact her directly and say, I want to come. It can be kept anonymously. And and we have some things planned. We will gradually, if anyone has any feedback, please do get in touch with any of us. Yeah, thank you.
Thank you, Dr. Chitra and Ria, for your comments. Now the topic is open for discussion, so I invite all the senior faculty members and other important staff, admin staff, to please contribute to the discussion.
Thank you, Chitra, for the tremendous presentation. What you presented here resonates well with me, because I am one who walked around for a whole week during my first year MBBS with a rope in my pocket. I survived that, and I was able to save 2 of my classmates from suicide. One of them committed suicide during his PG when I was not there, and the other one became a psychiatrist in New York. So this subject is very close to my heart. Thank you for bringing it to our attention and presenting it so well. Thank you.
Thank you, sir. We know that diabetes, hypertension is taking away lives, and we see all these components as a very important part of lifestyle diseases like cardiovascular diseases, cancer. But do we really take in stress, the pathophysiological changes which happen in body, the telomere shortening, the inflammatory markers which rise in the body? Are we testing it? No. But do we have symptoms? Yes. Is it possible to test TNF-alpha, interleukin-1, interleukin-6? No, we cannot. But we can identify the clinical symptoms. So it's not only for us, for our patients also, I think it's equally important to treat these aspects so that we address the patient holistically.
Almost a human life is totally changed and is evolutionized from the unrefined food to refined food. This may be gut dysbiosis, and there is happening in the neurochemistry. What is your opinion?
Sir, we have a lot of patients who are referred from gastroenterology department, and I would say around 50 to 60% of patients who are coming to gastroenterology are having anxiety and depressive symptoms. So we have a lot of patients who have GI symptoms who come to our OPD, who get better with psychotherapy and psychopharmacological interventions. And then we find that when they take in some specific food, they have these anxiety symptoms. Their life will be perfectly fine. They don't have any stressors, nothing. They get the bad food here, the anxiety, the depressive symptoms get triggered. So it works both ways, and it's a well understood concept now. And I think George Andy sir is also here to.
Suman, thank you. I want to say something different. Last 2 or 3 weeks have been tremendous stress for the management because of all the happenings. And I wonder whether Chitra has answers for that. You know, because ultimately it's all thrown at us. So, in all your your whole presentation didn't address us at all. Jaco will answer.
We always talk about suicide as the most important thing that concerns us. Suicide is the tip of the iceberg. It's sometimes the converging point of so many stresses. We have to start right from the top. People just get alarmed and we go into the action mode when something actually happens. By that time it's too late to do anything. So the whole aspect is actually developing a culture of mental wellness right from the start. So we have to basically help a person maintain his happiness level in the midst of stress. It's not possible, or it's not practical to expect an environment where there's no stress. We have to combat stress. At the same time, it is possible to maintain some sort of a balance so that we maintain a happiness in the midst of stress. This has to be a general culture. So this can't be the end of it. All those things, these are all emergency measures, most of these suicide prevention measures. They are not holistically designed to help a person design himself into a better human being. So I think we always talk about band-aid solutions. We have to start from the transformative aspect of it, which is promoting mental health. And just as Monvarghese sir has mentioned, the gut-brain axis, these certain subtle things that are actually coming into focus right now. We have more microbes in the body than our whole cells. And these microbes are there because they serve a particular purpose. Just to quote a simple example, we talk about serotonin, because SSRI is one of the most dominant drugs. We have more serotonin in our gut than in our brain. That's just a clue. So it's almost like a second brain. And the funny thing is, in many of the ancient Chinese documents, they have also mentioned something called like gut brain or a second brain. So this is something that's been known to a lot of people all across cultures. That's why people have always insisted on the right diet to maintain the right mind. Now science is actually proving it. So sometimes the wisdom that we dismiss so casually is now coming back into focus. And our ancestors always stressed on harmony in life. They stressed on moderation in life. And we have kind of left all that, and we are going along a fast lane, probably towards an accelerated end. We can't say that our lifestyle has improved and we are happier than our ancestors. So perhaps we need to redefine what happiness is, what success is, how do we take care of each other. I think the end of it is people have to learn to be nice to each other. It's the simplest way of putting it. We have to ask ourselves, are we really being nice to each other? It's a very simple thing, but I think that kind of summarizes what we can do. When we are nice to each other, we feel good also. So that is a kind of symbiotic ethos that has to come in. This is just a suggestion. There is no perfect solution, sir. Fortunately, I don't have a perfect solution. Thank you.
Thank you, Jaco sir, for your insightful comments.
Let's take a few moments to welcome the newly joined members of our family. I would like to welcome Dr. Leda, who is a senior professor in pathology. Please, ma'am. Ma'am has 35 years of experience and has joined us. Dr. Alex is not new to us, but Alex has rejoined us. Please, Alex. Alex in forensic medicine. Thank you. We have some DRNB residents who has joined us. Thank you for choosing us. Dr. Reshma Raju from gastroenterology. Please, ma'am. And Dr. K. Vinay Gautam. Dr. Patel Miran. Dr. Annapurna V, who has joined neurology. Dr. Bobby is not new to us. Bobby Abraham, clinical hematology. Dr. Sudhir Venkatesh, please. And Dr. Tinson and Dr. Sinsi is not new to us. They are already with us. They have joined in as DRNB residents in critical care medicine. So these are our newly joined members of our family. Welcome. Welcome to PCMCH, and thank you.
Tell your bosses to let you come for Quest every Thursday morning, 8 o'clock.
Thank you. So see you next week for the Quest. Thank you.